Many accessory muscles of the hand and wrist have been described. Most are incidental and asymptomatic. Others can be implicated in compressive neuropathies or simply present as a palpable mass. I find them fascinating, an example of the nuances of anatomy that as MSK sonographers we are students of. What follows are the ultrasound appearances of some of the more common accessory muscles that we encounter of the hand and wrist. On the dorsum of the wrist, the extensor digitorum brevis manus muscle is found ulnar to the extensor tendon of the index finger. Typically this presents as a palpable lump, query ganglion or carpal boss, and is an incidental finding. The muscle bellies of the extensors should not extend to the carpal bones. If there is a muscle that does do this, then this is the extensor digitorum manus brevis muscle, thought to be present in around 3% of the population. On the volar aspect of the wrist, normally there shouldn't be anything between the FPL, FCR and the distal radius. But between 2 and 8% of the population there can exist an accessory muscle, the flexor carpi radialis brevis vel profundus. It extends from the distal radius to the capitate and base of the third and fourth metacarpals. Typically this is an incidental finding, though can increase the likelihood of developing an intersection syndrome. Ganse's muscle is an accessory FPL muscle within the forearm. Some authors suggest its presence is around 70% of limbs and therefore question whether it should be considered normal rather than an anatomical variant. The easiest way to identify Ganse's muscle is to scan the FPL tendon proximally. By flexing the thumb we can see the FPL muscle bulk move. If we continue to see a muscle move proximal to the main head of the FPL muscle, then we have an accessory FPL muscle or a Ganse's muscle, which can contribute to median nerve or AIN compression. On the volar and ulnar aspect of the wrist, originating from the antebrachial fascia or the palmaris longus tendon, is an accessory muscle which sits anterior to the ulnar nerve, adjacent to the pisiform, and is the accessory abductor digiti minimi muscle. Present in around 24% of the population, the accessory abductor digiti minimi can potentially irritate the ulnar nerve at Guyon's canal. The palmaris longus is the upper limb homologue of the plantaris. It's absent in around 15% of the population and is frequently harvested and used as a graft for multiple surgeries. Typically, its muscle is proximal and the tendon distal, though it can be reversed, such as in this case, where the tendon is proximal and the muscle distal. A reversed palmaris longus can be a potential cause of a compressive neuropathy of the median nerve, and a digastric configuration of the palmaris longus has also been reported. And a muscle that, while not accessory or a variant, is often mistaken for one is the palmaris brevis. The palmaris brevis lies in the subcutaneous tissues volar to the ulnar nerve, distal to the pisiform, and inserts into the skin. It's a muscle we have probably all scanned but not realized. There are a few more accessory muscles of the hand and wrist that have been reported in the literature that remain unchecked on my bingo card, though those just described certainly are the most common and significant that we'll encounter in ultrasound. Thanks for watching guys, like and subscribe for more.